So everybody, I am happy to see you. I would like to see you by person. I will try to explain what's going on in Italy with this issue. So I'm very happy that I've been preceded by Axel because he was able to explain much better than I can do what's going on with this patient. Next slide, please. Okay, so when we look at what's going on, we see there are very, very few green faces. I mean that we don't have anything now really working in this kind of patient, apart from invasive ventilation, PE, pronation, and so on. There are a lot of studies going on about the use of immunomodulation and so on, but really we don't have any definitive treatment. Next slide, please. Next. Okay, so we go back to last Easter. No, we go back. Okay, so thank you. We are about last Easter, and on the JAMA has been published a paper whose conclusion that no therapies have been shown effective to date, and more or less at the very same point. Next slide, please. Actually, as Axel said much better than I can do, there are a lot of papers showing that in COVID-19 patients, a sudden rise, a relatively unexpected rise on several cytokines, including IL-6, IL-2, TNF, and so on. This is relatively well known at the present time. Next slide. Of course, there are several different phases. In the first phases, there are bacteremic phases, and where only the lung is hit by this infection. Then another phase occurs, which is characterized by the release of the massive relief of cytokines, and with the damage of organ different than the lung. Next slide, please. When we look at the extracorporeal technique, we can separate two different families: blood processing techniques and the plasma processing techniques. The blood processing techniques that last arrived, but not the least, of course, the CytoSorb, which is able to stick on the surface of some microspheres, on the microbits, a lot of mediators with either pro and anti-inflammatory properties. Next slide. Different techniques can be used for support different organs, but as far as we want to treat the whole organism, I think the hemabsorption can be really the magic bullet. Next slide. Next slide, please. Okay, next slide one again. We in Trieste, but I should say also suggesting all over Italy, we have been inspired by this paper published by a Roman doctor, Dr. Bottari, who treated a patient, a baby actually, with acute lymphatic leukemia with a molecular dysfunction following CAR-T treatment, and they were able to reduce the burden of mediators as well as to improve gas exchange of whole body organ function. We use at the same time tocilizumab and CytoSorb. Next slide. I don't want to waste time to describe once again the CytoSorb. Next slide. Actually, this technique is able to remove a huge amount of different substances, and there is a paper, really a recent paper, showing that some drugs used in actually not very often used now, using patients with COVID-19 infection, including chloroquine and azithromycin, are not removed by this technique. Next slide. A huge amount of different mediators are removed by these techniques. I would like to next slide, please. I would just to see what's going on with IL-6 in the patient treated with this technique, 60-shot patient treated with techniques. As you can see, actually, there are animals, sorry, this is an animal model. There is a good decrease of interleukin-6 as compared, for instance, with TNF-alpha, which is not removed so efficiently. Next slide. I show data coming from my unit showing the IL-6 variation during CytoSorb in a patient with septic shock mediastinitis. As you can see, the decrease of interleukin-6 is very, very strong, peaking at the -84% after the first day. Probably, should we have to change the cartridge after, let's say, 8 to 12 hours, the decrease could be also even even stronger. Next slide, please. Looking back at septic patient, we can see this is a paper which has been selected for publication, indeed with more or less 60 patients, and which are the key factors are the duration of the treatment and the intensity of the treatment. Even on the contrary, what could be expectable, the free treatment interval is not as much relevant in order for the outcome of patient. Next slide. But another substance, another approach, pharmacological approach, has been widely used in Italy, which is the use of tocilizumab, which is an anti-interleukin-6 receptor antibody. In a few words, this antibody, the recombinant antibody, is able to remove the interleukin-6 molecules from the both cell and circulating mediators. So a huge amount of interleukin-6 is released, but without any residual biological effect. Next slide. Apparently, interleukin-6 a key mediator in different inflammatory reactions. Next slide, including COVID-19 infections. This is a paper coming from China, showing that indeed the surge of interleukin-6 is not immediate. As you can see, it takes from let's say 10 to 13 days to peak. As this can explain why the use of the early use of tocilizumab apparently is not effective to the patient, probably because there was no any substantial rise of this molecule. Next slide. Actually, there are a couple of papers coming from Italy showing with the observational studies showing the patient treated with interleukin-6, with tocilizumab have a better survival rate as compared with patients with treated with tocilizumab. Next slide. This is our experience. As you can see, this is a patient coming from another town. He was a 42 years old guy who was very, very fit and very strong, was admitted for use after 2 days in another unit. And the symptoms started 7 days before our admission. The patient was treated with a conventional approach with the prone position and so on. Next slide. But a couple of hours after the admission, we start with tocilizumab and CytoSorb. As you can see, after after 24 hours, the interleukin-6 decreased. This is not very strong decrease as compared with the slide I showed you before, because when you measure interleukin-6 after tocilizumab, there is a rise, a peaking of blood levels because the molecule is in the bloodstream, but it's not more effective. CRP has the same, let's say, it's the same for the same way, and the PO2-VO2 ratio increased. Next slide. And actually, after the 3 days, this was a situation where the patient has been discharged to a subintensive care unit. Next slide. We measured interleukin-6 level as well as other variables in patients treated with tocilizumab alone versus tocilizumab and CytoSorb. Next slide. As you can see, patients receiving tocilizumab had the apparent increase, actually, well, a real increase of blood levels, but were not biologically active, where a patient treated only with CytoSorb demonstrated a good decrease of interleukin-6 level. Next slide, please. So these are the, how to say, the role of engagement, sorry for the Italian, in Trieste, where I can live. As you can know, there is the same role engagement in other ICU all over Italy. So when we have an interleukin-6 or CRP levels normal, we don't give tocilizumab, we don't apply CytoSorb. But in case of interleukin-6 raised or CRP, but without organ failure and no other infection, PSP and new marker indicating pancreatic stone protein, which is supposed to be a good indicator, near indicator of infection as compared with PCT. We start with tocilizumab, but in the case of increase interleukin 6 and or CRP and the failure of other organs out of the lung, we start at the same time cytolizumab and CytoSorb. Of course, the patient might be reassessed every day. We have to look for secondary infection, and in a very, very early phase, we are thinking to use anakinra, that means is interleukin-1 receptor antagonist, which is supposed to work better in the initial phase of disease as compared with tocilizumab. Next slide, please. This is war failure because we treated the patient with CytoSorb in the very few days of his life. I have this patient, as you can see, that a lot of thrombi, a lot of embolisms, and a lot of hemorrhagic pulmonary infection. I think that should we have treated the patient earlier with CytoSorb, probably the patient could be survive and go back home as we did with other patients. As you can see, there's a small vessel of the lung with the thrombus inside, and there are also thickening of the arterial wall. So next slide. This is my final slide. This is Trieste. See from my plane. I hope to see you in Trieste and I promise you to fly with you over my town. Thank you for your attention.